Hello, my name is Stella Sue. For my project, I focused on automated brain tumor segmentation and radiomics marker identification for survival prediction. Gliomas account for one of the most common malignant primary brain tumors. Patients with aggressive high-grade gliomas have life expectancies near 15 months and a very grim prognosis, even with an aggressive combination of therapies. Additionally, manual brain tumor segmentation is very challenging and prone to significant intra- and intervariability. In the winning model for the BRATS 2019 challenge, the survival prediction model had a very large survival prediction error of 314 days. My goal for this project are to develop an automated brain tumor segmentation model through machine learning, build a more accurate survival prediction model than the state of art, and to identify radiomics markers through model-based feature selection to determine tumor severity for survival prediction. Our workflow consists of the following modules. The first module takes multimodality MRI scans as input and produces tumor subregion masks. Next, the tumor subregion masks, as well as the multimodality MRI scans, are used to extract features. These features are then fed into a feature selection and survival prediction model to predict overall survival time. The overall survival time, radiomics markers selected from the extracted features, and tumor subregion location can then be used to assist in clinical applications such as survival curving, tumor prognosis, surgical planning, follow-up assessment, and clinical trials. The first module is brain tumor segmentation. The brain tumor segmentation dataset used was the BRATS 2020 challenge dataset. This dataset consisted of 369 patients. Each patient had 4 modality MRI images, T1 weighted images, contrast enhanced T1 weighted images, T2 weighted images, and FLAIR images. MRI images for each patient were co-registered, resampled, and skull stripped. 3 ground truth tumor subregion labels, edema, enhancing tumor core, necrotic, and non-enhancing tumor core, were also provided for each patient. The first step in brain tumor segmentation process is data preprocessing to allow for data from different institutes. N4 bias correction is applied to all images to remove low frequency, non-uniformity in the MRI images. Each MRI image is also trained to have 0 mean in the unit standard deviation. Next, the segmentation model was created using a 3D unit architecture. During training, patches were created based on the cuboid boundary of the brain. These patches were then resized to 128 by 128 by 128 voxels. The model was trained using batch size 1 with an atom optimizer and an early stop mechanism. The performance of the brain tumor segmentation model was measured with Dice coefficients. This table shows the mean of the Dice coefficient for 3 tumor subregions. The distribution of the Dice coefficient to the 3 tumor subregions is depicted with a whisker plot. Here is a visualization of the original image, the ground truth, and the prediction. Here is a 3D visualization of the original image, the ground truth, and the prediction. Next, we calculated survival prediction. The dataset we used for survival prediction was the BRATS 2020 survival challenge dataset. This dataset had 236 GBM patients with the information regarding age of the patient, survival days, and resection status. Gross total resection, subtotal resection, and not available. In feature extraction, we experimented with handcrafted features from segmentation masks and radiomics features generated using a PyRadiomics package. The handcrafted features from the segmentation mask, volume from each tumor subregion, surface area from each tumor subregion, and surface area from each tumor subregion. The radiomics features generated using a PyRadiomics package included shape-based features characterizing the shape of the tumor contour, first-order statistical features characterizing the tumor intensity distribution, and textural features characterizing spatial intensity distributions. One survival prediction method is linear regression. The linear regression model was made up of fully connected neural networks with 2 hidden layers and 2 dropout layers, trained on the 8 features, volume, and surface area from the 3 tumor subregions, age, and resection status. Another survival prediction method is random forest regression. Random forest regression performs very well even when there are many features but few training data. A random forest operates by constructing several decision trees during training time and outputting the mean of the classes as the prediction of all the trees. This figure shows the result for linear regression with an early stopping mechanism. This table shows the survival prediction result for a random forest regression model and the linear regression model trained on the 8 features, volume and surface area for each of the 3 tumor subregions, age, and resection status. Note that linear regression is not as stable as random forest regression. Many trial runs were performed to get these results. Feature selection is a very important step given the large amount of radiomics features generated by the PyRadiomics package. Random forest regression on survival prediction is also used to find the most important features. The first step in the feature selection process is to train a random forest regressor with 1,000 trees on survival prediction using all the radiomic features. Next, we find the 50 most important features and create a dataset containing these features. Finally, we train another random forest regressor with 100 trees on the new dataset of features to predict survival time. This table shows our survival prediction results for the random forest regression model trained using radiomics features. We experiment with different combinations of radiomics features with and without feature selection. The combination of shape, first order, and GLCM of original image, age, and resection features achieved the best results. This plot shows the feature importance for survival time prediction for the top 20 features. We identify the radiographic markers for tumor severity and survival prediction through feature selection based on the survival prediction model. In conclusion, we developed an automated brain tumor segmentation and survival prediction model to reduce the workload for radiologists and prevent intra- and intervariability. We identified non-invasive radiomics markers from multi-parametric MRI and tumor segmentation masks to determine cancer severity and predict survival time. We also achieved a higher accuracy for the survival rate prediction and reduced the error from 314 days to 299 days. In the future, I hope to use these techniques as a tool to assist clinicians in accurate tumor prognosis, surgical planning, follow-up assessments, and clinical trials. I also hope to extend my current work to finding radiographic markers for molecular subtypes, which can lead to personalized diagnosis and treatment. Here are my references, and thank you for listening.